What I thought I'd talk about today is, or the organisers encouraged me to cover, was a brief update of hepatitis C, which Scotty's done very nicely, which means I can focus more on hepatitis B, where I'll cover existing assays and probably more of importance and relevance is assays in development that will help us in terms of our next steps to cure for Hep B. So in terms of hepatitis C, WHO have released the recommendation for managing patients with chronic hepatitis C, looking at the screening and the care and the treatment pathway. And as Scott mentioned today, really antibody testing and PCR really is where it's heading. And I don't think the conclusion that you come to in the viral hepatitis space is that hepatitis C testing is going to get simpler. Hepatitis B testing will go in the other direction. So I think the questions that seem to be not quite clear in the hepatitis C space is what defines cure in the era of DAAs from a laboratory perspective. Will it be SVR12? That seems to be the safest. People are sort of trying to push it back a little bit. And so really we can distill down laboratory tests in the DAA cure era for Hep C into NAATs, the core and the thing that we often is forgotten, the importance of having these assays, certainly the amplification assays, on a uniform platform or a polyvalent platform so that you can do at least Hep C, Hep B and HIV altogether, like what we saw with PEPFAR in Africa. And also, Scott's also introduced the importance, potential importance of the Hep C core antigen assay. So I think if we're going to look at the way the Hep C core antigen might work in Hep C, just to sort of know some of the characteristics of the assay, it is detected in blood roughly at the same time as Hep C RNA, just a couple of days later. 1 picogram of the core antigen is equivalent to about 7,900 international units per mil of the Hep C RNA. On the Abbott Architect platform, seems to be the cutoff of around 1,000 is comfortable. It's equivalent to 3 femtomolar of core antigen. So the assay seems to be hovering around detectability of the core antigen assay by whatever technology, around 1,000 international units per mil. And Scott showed some data to support that. And you can come to the conclusion, though, that you will miss 5% of individuals with viremia, and typically that viremia of around 3,000 or less. And we have to ask, is that acceptable? And I think most people are saying it is acceptable. And there's been a very good correlation between RNA and core antigen testing at RNA levels above 1,000 for all the genotypes, and I think that's very important. And importantly, in terms of therapy, decline in core antigen does correlate with decrease in RNA. There doesn't seem to be a lag period, and so like it's a direct effect. And so a test for Hep C core with a lower limit of detection of around 1,000 would be, I think, sufficient for monitoring. And I think that's where the field's headed. So if we sort of, I think after this week in AASLD, where we're going to see some more staggering numbers about cure rates and SVR12s, the latest regimens will be hitting between 95 and 100% from what I've seen of the abstracts. So what about 5% of the non-cures? What are we going to do with them? Well, 5% of a lot of people is a lot of people still, and you can argue, well, how are we going to manage that 5%? People are talking about the role of resistance-associated variants. Do we start providing resistance testing? Certainly not at baseline, and probably not now until we learn a bit more about these drugs and the various combinations that we're going to see clinically. But my sense, based on what I've seen coming in the literature and practically, is that probably not ever will I see that the need for a resistance testing. I'll make a very brave prediction and say not ever, because the thing that amazes me about hepatitis C is the excellent rescue regimes that are being already developed for viral breakthrough before we've even had them. So it's an amazing space, an amazing period, and I think let's quickly move away from hepatitis C because it's pretty well finished, and we can move on to something that's not finished, which is hepatitis B. So here's the WHO algorithm to manage patients with hepatitis B, and you can see this was released this year, as it was mentioned in the session before. And on your left, it's not a very good slide, but on your left you can see that the decision was made by WHO expert committee to grade on the basis of disease, so cirrhosis straight up, yes or no, without any amplification test. You just needed to be hepatitis B surface antigen positive, cirrhosis, clinical or laboratory diagnosis, preferably FibroScan would be nice. You earn treatment, and the treatment is first line, entecavir or tenofovir, and that is the WHO recommendation, and that treatment is for life. Now, on the other side, cirrhosis, no, but do you have a disease? And yes, you'll need to sort of then be stratified on the basis of viral load testing, so there is an amplification step required for the non-cirrhotic diseased hepatitis B cases, and then the rest of the algorithm sort of flows from there. So really, surface antigen and test and a Hep B PCR. So I think what I thought I'd do in terms of now the boutique test that we want to discuss, and I think really say, well, what does the field now need in terms of going forward in curing hepatitis B? We need to sort of agree on some questions, and Scott highlighted the ICE-HBV strategy. We really have no consensus and no forum for consensus in the hepatitis B space. So hopefully the ICE-HBV strategy will be just that. So what do I think a hepatitis B cure would look like? In the blood, you'd be DNA negative and surface antigen negative, and ideally anti-HBs positive. But in the liver, and we have some debate with our hepatological colleagues, obviously a cure would require no cccDNA or mini chromosome, no HBV replicative intermediates like relaxed circular or double-stranded linear, and a third intermediate that's sort of single-stranded DNA. The core antigen staining would ideally be negative, and certainly in the nuclear core, and certainly absent in the cytoplasm as well. But I think we would accept some surface antigen staining, and the reason for that would be that would reflect integrated HBV DNA. And I'll present some data for some recent studies out of Hong Kong showing the importance of integrated DNA in the natural history of chronic hepatitis B, and how integrated DNA is really going to affect our definition of cure. All right, so what we've agreed so far and what we've put into the ICE-HBV document is a functional cure is defined simply as surface antigen loss with seroconversion preferably. Not essential, because S antigen negativity eventually results in S loss as well. An absolute or complete cure, which is very optimistic and idealistic, maintenance of undetectable serum DNA off treatment, that seemed pretty reasonable, but really the definition or the requirement for no cccDNA anywhere in the liver, I think, is very optimistic. And over the last 15 or 20 years that we've been trying to cure hepatitis B, with the various studies that have been done and the molecules and approaches applied, I think we can reach these three conclusions pretty easily. What are the barriers? This reservoir of cccDNA, what is it? Well, that's another afternoon symposium. As Scott said, a lot of us have spent half our lives trying to look at it and understand it, and I think we know less about it now than we ever did. But I think we have to agree that the immunologists have probably got a role, and that there is a dysfunctional T-cell response. Whether that will get fixed on reduction of viral load and viral proteins will be a very intriguing part of the natural history of curing hepatitis B. And I think what's emerged recently is the importance of the B-cell response. We've really underscored and underestimated and ignored the B-cell response, and I think to our peril, because again, emerging evidence from some recent studies have shown the importance and the way the B-cell response can happen as we inhibit particular aspects of HBV. So there have been a number of strategies and clinical trials that are being looked at the moment to overcome these barriers, such as how do we turn it off, the cccDNA, how do we silence it, how can we get rid of it, how can we destroy it. I think there's been discussions about potency of polymerase inhibitors. Do we need any more? Is TAF going to be enough? Can we broaden our viral targets to look at other proteins, X, S, core? And what will that mean in terms of how we're going to measure the efficacy of these particular compounds? And then how are we going to put all that together, really, because no single drug, I do not think at this point in time, will be adequate to actually cure hepatitis B. So again, to acknowledge the importance of the immune response, I will actually include activation of antiviral immunity. All right, so on this excellent review that was done from the NIH is a very, very nice summary of the new targets that have been listed here very clearly for attack. So we've got the first one is targeting cccDNA. Then, can't read it from here, but the next one after that will be, okay, so actually, so I'll back up. So here is the receptor, so we're blocking the receptor and attachment, then targeting cccDNA generation and processing. Then here, looking at blocking RNA transcription, replication in terms of the replication complexes, and then looking at surface antigen secretion and other viral proteins would be the key parts of it. Now, this is sort of like the typical life cycle of a virus, covering all the major things of hepatitis B. This is sort of the drugs that are in development. But really, one of the challenges we're going to find, I feel, is that we don't necessarily have the right tools to be able to measure the actual impact of these molecules on the life cycle of HBV. And that's what I'd like to discuss with you now. So what do we think some of the tools needed in 2015 and beyond to really demonstrate at least a functional cure? Well, we're going to need the PCR for HBV DNA. It needs to be negative in serum. We've already got qualitative e-antigen assays, but have we got quantitative e-antigen assays? Sort of various platforms are coming out and are being released by diagnostic companies now, calibrated to the Paul Ehrlich system, and so that really will help us a bit to be able to show not only improved staging, but indeed an antiviral response, focusing on the E protein. We've already got qualitative and quantitative surface antigen assays. They seem to be performing pretty well, but I think there could be a slight genotype issue, and they certainly don't take into consideration the importance of coexisting antibody as what we've identified in most patients with chronic hepatitis B. The hepatitis B virus is growing in cell culture now, and with the discovery of the NTCP receptor. And so the question about, is this seroconversion actually a neutralizing one? Is it truly broadly neutralizing like what we're trying to achieve in HIV? Or is it just sort of is there a mixture of non-neutralizing as well as neutralizing antibody? And so a number of investigators, including my lab, have been developing epitope mapping assays for the surface antigen to look at the effect of the emergence of a de novo or a pre-existing anti-HBs response. So these are the sorts of things that we would need to have to be able to render people e-antigen negative, S-antigen negative, and seroconversion for a functional cure off treatment. Now, for a complete cure, obviously we'd need still PCR for DNA negativity in serum. Also, a good PCR to show that we'd lost all intrahepatic cccDNA for whatever intervention we went for. Could we do that with surrogates? There has been a claim for using quantitative surface antigen in e-antigen negative patients that would reflect the level of intrahepatic cccDNA. We actually published a paper in support of that, but it certainly didn't hold up for e-antigen positive patients. I'll put it up early, but the surrogate for the integrated HBV DNA is going to be an important one in terms of e-antigen negative disease. So all of this changed this year with Arrowhead and their studies of ARC-520 in Hong Kong. And so ARC-520 is an RNAi molecule which delivered in a DPC system releases their RNAi inhibitor into the cytosol, into the RISC, and actually blocks transcription of a key part of the HBV replication cycle. It blocks all 4 transcripts at the cohesive overlap region, and was in vitro and in animal models in the transgenic mouse a very effective inhibitor of HBV. Now, then they started their clinical trials. And so leading into their clinical trials, they were also running the chimpanzee studies. They had 9 chimps that they were looking at. I think 4 or 5 e-antigen positives and 4 e-antigen negative chimps. And they got some very interesting results. In the chimps, the mean knockdown of their ARC-520 compound in the e-antigen positive animals was very impressive with just a single dose of 2.1 logs of surface antigen. And that was actually the first time that there'd been a true dose-response effect with an antiviral affecting the surface antigen protein. However, this impact on the e-antigen negative chimps was very modest. At best they got was a 0.7 log reduction, and even with multiple dosing, they hit the floor. They were unable to show any more antiviral effects. So there was clearly a difference between the E antigen positive and the E antigen negative chimps. And so the novel finding was in collaboration with Robert Lanford. They were able to do multiple liver biopsies of these animals, and to the surprise of everybody on the advisory board, most of the HBV DNA that Robert was able to show with a PCR strategy and a Southern strategy, looking at episomal and integrated HBV DNA, that most of the HBV DNA in the E antigen positive animals, because these were nuke suppressed on entecavir, was CCC DNA. In the E antigen negative animals, it was the complete opposite. There was a 500-fold less copy number of the CCC DNA transcript, and only 5% of the total liver DNA in the E antigen negative animals was the mini chromosome, and the rest of it was actually integrated. And so they realised that 90% of the DNA in the E antigen negative animals was actually indeed integrated HBV DNA. So the conclusions of the ARC-520 study in the chimps, and has now since been, and this will be presented as an oral at AASLD this week, is that the 520 certainly gave a robust and sustained antiviral effect in surface antigen production in all of the E antigen positive animals with up to 2.7 logs, but only a 0.9 log in the best knockdown effect for the E antigen negative animals. It was well tolerated at 4 milligrams per kilogram, which is the dose that's going into the clinic. But really, the molecular virology data showed very nicely that in E antigen negative disease, integrated HBV DNA is an important source of the total surface antigen that we measure in the peripheral compartment of these E antigen negative chimps. So we started to realise that the life cycle that we've been talking about for the last 20 years was a little bit naive. That in the pre-ARC-520 era, hepatitis B virus basically was seen as a virus that E antigen positive, made lots of sort of E protein, X protein, core, all of the other surface antigen, replicated in the cytoplasm and the replication complexes, assembled and released. What we failed to realise was that in E antigen negative disease, that there's a replication shift. And the replication shift is that the E negative pathway is blocked or not functional, and for whatever reason, probably because of clonal selection, we see a shift to the double-stranded linear replicative intermediate, shown for you here on the lower left-hand corner. So most of the replication complexes generating rcDNA, which are then dephosphorylated and rephosphorylated and then secreted. That's a minor pathway in E antigen negative disease. A major pathway is this intracellular reamplification through a failure to translocate a primer in the replication pathway of reverse transcription, generating this unique intermediate double-stranded linear DNA. And Jesse Summers then has gone on to show that this is the major pre-integrative precursor for HBV DNA, and that 99% of HBV DNA integrated in both a human and in a chimp is actually this DSL replicative intermediate. So E antigen negative HBV replicates in quite a different way from E antigen positive hepatitis B. Now, that has enormous therapeutic implications because we've seen here the traditional blocking pathway of reverse transcriptase inhibitors with entecavir and tenofovir. We've been talking about these for 10 years. Along comes the ARC-520, and what we realise is that only in E antigen positive disease does the ARC-520 actually work. Now, the ARC-521, which is a new RNAi inhibitor that Arrowhead have now made it to the open reading frame of S in order to be able to achieve the S antigen reduction, to achieve a functional cure endpoint. So ARC-520 or the nukes will work in this particular pathway through this non-integrated episomal DNA pathway, and this next RNAi molecule, which is targeted exclusively to the open reading frame of S, is now working effectively on the non-episomal but the HBV DNA integrated pathway, and thereby achieving S antigen reduction. So to sort of summarise these, I think, very important findings for the hepatitis B field, that certainly the RNAi inhibitors work both in chimps and in humans. We've got similar data, which will also be presented as a late breaker at AASLD from the clinical side, showing in E antigen positive humans a 2 log reduction, E antigen negative humans a 0.7 log reduction. So yes, that the chimp and the human data are mapped together, and that the direct antiviral effect on serum surface antigen and E antigen is substantial with the E antigen positive cases. But what I've tried to highlight, and I think which is important, is that the E antigen positive and E antigen negative natural histories have very different viral pathophysiologies, very different life cycles and replication strategies. And the emergence and importance of the HBV DNA as a source of surface antigen. Now, this is going to impact very heavily on our definition of functional cure in E antigen negative hepatitis B. So the next boutique assay that the field is basically considering using is HBV serum RNA. And we've all been a bit cynical in Melbourne about the importance of HBV RNA, and Scott and I have argued about it for a few years now. And so Florian van Bommel spent a little while in our laboratory trying to convince us that it was important. He still didn't, and he went back and he published his paper in hepatology. But basically, what he's on about is that he can measure serum HBV RNA diagnostically. He can do it quantitatively with a race PCR strategy, and I've shown his paper here for you and the strategy he's used. Now, if you have a look at the strategy here on the left, he's developed two PCR approaches where he can measure full-length RNA, and it's called FL-RNA, which measures the bona fide sort of polyadenylation site at the end of the HBV RNA sequence. And there's also, within X, a second polyadenylation signal, which is activated typically after integration. And so he's developed a second PCR called truncated or tRNA, which can hopefully be a surrogate for integrated HBV DNA. But in this particular study, and he's presenting an update also at AASLD, he's talking about using the HBV RNA assay as an early prognostic marker for E antigen seroconversion. And so really to summarise the key findings from his paper, this is his E antigen positive seroconverter cohort that he treated with an antiviral, and this is his E antigen positive cohort that did not seroconvert E antigen wise. And what he found was that in the PCR that he used for the full length and the truncated, there was a 1 log reduction at week 12 and another log reduction by week 24, and he could use the 1 log reduction at week 12 as a strong positive predictive value for E antigen seroconversion at 12 weeks of antiviral therapy. And so he did all the statistical analyses that hepatologists love to do, and he showed that the ROC curves at baseline, month 3 and month 6 are shown for you here, and at baseline HBV RNA for full length was actually a positive predictive value of potential E antigen seroconversion, but it was stronger at 3 and 6 months for the truncated form, and he was able to show that a 1 log reduction at 3 months was associated with significant sensitivity and specificity. So we now have a second assay, or an assay where we can now look at the possibility that the full-length serum RNA, which is not necessarily packaged in a core and not necessarily packaged as a virus, this particular RNA form, which we don't quite know exactly what it is, but does seem to reflect episomal or CCC DNA in the serum through a mechanism that we don't fully understand, and that the truncated form may be a surrogate, if used in a quantitative assay, of integrated HBV DNA. Now, obviously, this is going to require further studies and investigation. The virologists are now very interested, especially with the recent data about the E antigen negative hepatitis B story with integrated HBV. The other assay that you're going to hear a lot about in the next few weeks and years is the hepatitis B core-related antigen assay. And again, there are several posters and presentations at AASLD that are going to be talking about this. And this came out of a study from a Japanese group that tried to understand why in serum we see a lot of E antigen, a lot of empty Dane particles or virions floating around, yet the HBV DNA levels seem to be very high. And so you can see in this electron micrograph that there's a mixture of what we call full particles on the outside, and on the inside, the negative stain has penetrated the virus particle, and it's these empty staining, presumably DNA negative virions that were of interest to the Japanese group. And what they identified was that this is the pre-core core gene product in their processing. Here's the core protein, P21. Here's the pre-core protein, P25, which is then processed into the into the E antigen with N-terminal and C-terminal sort of cleavages, and they identified this other intermediate of the pre-core processing pathway called P22CR, which has got a full N-terminal end, a minus 29 amino acids, and a partly truncated C-terminal end. And so this has the ability still to actually package, to actually form a capsid and then be enveloped and secreted as an empty particle. And that, again, didn't get much interest until the company, or a Japanese company, picked up this concept and developed this ELISA assay. And the ELISA assay is supposed to pick up a mixture in serum of the core protein, the E protein, and this P22CR. Now, it's very hard to get any more detail than that these three proteins are in the ELISA mix. And that's what the actual HBsAg antigen is. And several studies out of Asia Pacific in the last couple of years have looked at the role or the significance of this core-related antigen. Here it is across the phases of chronic hepatitis B, and you can see that in the immune tolerant and the immune clearance phase it's quite high, reflecting the DNA levels. And here in the E-negative hepatitis phase is still elevated, but really in the quiescent E-negative phase, it's low or negative. And each one of these differences, certainly with the E-negative quiescent versus the other phases, it's actually quite statistically significantly different. It also correlates directly with surface antigen and DNA, and it correlates in this study published last year between cccDNA in the liver and the core-related antigen itself, both in E antigen positive, shown in the graph on the top bit here, and in the E antigen negative patients. So it would appear that we have a serum assay that can measure a novel sort of replicative intermediate process, of which we're not exactly sure either what that is, but presumably it contains a part of the E antigen pathway, and also is a surrogate for cccDNA that can be used in serum. Now, the only problem for us in Australia is that we can't get the testing kit to do this assay because it's a very expensive platform apparently, but I believe in the Northern Hemisphere it is available, so you will be able to get it here. So it's usually the other way around. So all up, it does look like this core-related antigen can be used to correlate strongly with disease activity. It differentiates quiescent from active E antigen negative disease. I didn't give the data, but it's also useful for occult HBV. It has the potential to have a predictor for liver cancer and also for S antigen seroconversion. And so it looks like, again, we've got another assay, not quite exactly sure what it measures, but it could actually be useful in helping us shape cure. So the fourth assay that I'll just highlight, that remember part of the functional definition is to actually make neutralizing or makes S antigen seroconversion. We assume that's neutralizing antibody. And just to remind you what the neutralization domain of hepatitis B virus is thought to be, it's the A determinant between amino acids 99 and 169, and it's a very potent conformational raft of cysteine and prolines, and it's known as the A determinant. And on this particular graph, here's loop 1, and here is loop 2, and here is the cysteine rafts here forming this conformational structure. So Renee Walsh in my lab has designed a 19 monoclonal antibody multiplex assay for this region of hepatitis B, and these are the various antibodies and where they react. They were all either commercially available or academically available, and using this assay she was able to define 5 regions in the A determinant that could be mapped with these 19 monoclonal antibodies. So what we were hoping to do was to be able to predict that during the process of S antigen seroconversion and S loss, that we would see immune pressure on the A determinant, and this would be translated into a diagnostic marker. And indeed we can actually see that. This is actually when we take a hepatitis B vaccine escape variant, G145R, and actually measure its epitope profile against the reference vaccine standard. There's only 1 point mutation difference between this and wild type, and you can see that there are 9 epitopes of the 19 that are actually either gained up here, lost, the majority, or they're actually a complete knockout. So this is a very powerful tool to be able to sort of see and follow the emergence of a sero-clearing anti-HBs response. So we had a hypothesis that we would be able to use these epitope changes to define a clearance profile, which we actually said was significant epitope changes against loop 1 and loop 2, or a non-clearance profile, which is either no change or only a epitope loss in loop 1 or loop 2. And we took a cohort of Gilead patients from their 103 registration studies. This was the tenofovir 103 genotype A cohort, where a significant number of surface antigen seroconversions occurred. And what we studied 25 patients, 14 seroconversions and 11 non-seroconversions, and we followed the S antigen changes against the epitope changes and identified that this clearance profile was indeed a valid biomarker with a statistically significant difference between the development of a clearance profile and the ability to be able to predict S antigen seroclearance versus the ability to not develop a clearance profile and therefore not seroconvert. And we'll be presenting this at AASLD as well. So what I've tried to do this afternoon is give you a flavour of how the molecular virologists are trying to provide new tools to be able to measure the ability of patients to sort of achieve at least a functional cure in chronic hepatitis B. So to summarise then, the goalposts are certainly shifting in hepatitis B and C, and as I said, in different ways. Hepatitis C is getting simpler, and I think hepatitis B is going to become a lot more fun for the virologist. In hepatitis B, the medium-term goal is to achieve cure, and ideally with S antigen seroconversion. And I think probably some form of immunomanipulation will be required to actually accentuate that process. We're seeing many new DAAs coming in for hepatitis B, mainly molecular-based therapies. And so one of the challenges and the opportunities will be improved delivery to the liver, especially with the molecular therapies. But I think these new HBV biomarkers that we've talked about today, like serum RNA, surface antigen epitope profile, and core-related antigen, really give the clinician and the virologist opportunity to really test new compounds. And I think the message I will leave you with is that what I was really staggered about this year, the fundamental molecular difference between E antigen positive and E antigen negative hepatitis B, the role of the mini chromosome and the role of integration. There's certainly palpable optimism in the hepatitis B space. We're very excited about what's happening, but we really do feel sorry for our hepatitis C colleagues because you're all done and dusted. Thank you.